Hi, my name is Brandon Earp. I'm a hand and upper limb surgeon at Brigham and Women's Hospital in Boston, Massachusetts, and I'm going to speak today on distal radius fracture fixation and offer some pearls and pitfalls for volar plating. These are my disclosures. And this is my disclaimer. I love taking care of distal radius fractures, and ORF of these injuries is one of my favorite procedures. I particularly enjoy using volar locking plates and feel that most distal radius fractures that require surgery can be best treated with a volar locking plate. I strongly prefer to do one surgery rather than commit a patient to a second surgery for removal of their hardware. And over 90% of the surgically treated distal radius fractures in our institution are treated this way. These are some of our learning objectives, and we'll go through them. In background, the radius is the most common bone in the arm to sustain a fracture and accounts for a significant minority of emergency department visits overall. There is a bimodal age distribution, with younger, healthier patients tending to have higher energy injuries and older, more frail patients tending to having lower injuries, such as a fall onto an outstretched wrist. There is an increasing incidence of these injuries due to osteoporosis in our population. The distal radius skeletal anatomy is kind of complex and beautiful. It begins at the metaphyseal flare. There's an articular surface that's biconcave and triangular with an apex at the styloid and the base at the DRUJ. And there's two facets, the sigmoid and lunate notches, and then the sigmoid notch as well. Ulnar variance, when we're thinking about what do we look for fractures in terms of when we're going to need to fix them, we start off with many radiographic parameters. We'll go through those. So ulnar variance, which is basically the difference between the length of the ulna and the length of the volar aspect of the distal radius. And there's normal variance in patient populations, but once you start seeing significant ulnar positive variance, it typically means that the distal radius is shortened. We also look at radial inclination, typically should be about 22 degrees. When that's flattened down, it means that we've lost this and we need to restore that radial height. Dorsal inclination or dorsal tilt, the normal is about 11 degrees of volar angulation, and when we start getting increasing amounts of dorsal angulation, that can affect the mechanics of the wrist and potentially indicate patients for surgery. Articular step-off, where there's gaps between fracture fragments in the joint, where there might be depressed or die punch injuries, need to be addressed. When there's associated injuries such as dorsal comminution, which then lets you know that there's poor integrity or structural support for any short-term reduction that you might achieve. Whether there's ulnar styloid fractures or a variety of other injuries, we just kind of want to think through those. Sometimes adjunct imaging can be helpful. It's expensive, so not always done. CT scan is the one. If I'm going to order something else, it's most commonly going to be a CT scan. Typically means that there's a pretty complex fracture pattern, and I'm trying to understand the pattern, assess for other injuries in the carpus potentially, and make a surgical plan. But I don't do this commonly, actually. MRI are almost rarely ever used, but it can show some other soft tissue injuries, and some people may choose to do this a little bit more commonly than I. So when we think about surgical indications, when you start having increasing amounts of dorsal angulation, shortening or ulnar positive variance, step off of the joint surface, loss of volar tilt, or DRUJ incongruity, we start thinking about surgery. And patient parameters also come into play. So higher demand active patients who want to get back to their activities, polytrauma patients who may have significant comorbidities and need to weight bear to allow them to mobilize, and other comorbidities requiring early mobilization may be useful for a surgery. But also, when you think about the initial displacement, the larger the initial displacement, even if you get a good reduction, the more likely you are to have subsequent redisplacement over the weeks as the fracture heals. If there's comminution, obviously poorer structural support. Or if you start to see loss of a reduction over a week or two, and then, of course, if there's an open fracture or acute carpal tunnel syndrome, those patients need to go to the operating room. And I did an acute carpal tunnel syndrome just last night for a patient who came in. Age is important. So Age is relative, of course, and there's some elderly patients who are incredibly vibrant and some younger patients who aren't. But it's important to involve the patient and potentially their family, if appropriate, in the process of decision making. We know in the older patient population, they can tolerate significant amounts of malunion and still have really excellent results. So important to have a patient-centered discussion about options. The biomechanical rationale for volar locking plate is that basically you have this volar plate that sits on the volar cortex, and then you have these locking screws that go through the plate and then lock in, creating a fixed angle device. And so some of them angle typically in most implants in this direction, which supports the dorsal articular surface, and some aim back a bit, which supports the volar surface. And the combination of those creates a cradle or a raft that supports the subchondral fracture fragments while this all heals or knits together, even if there's significant metaphyseal bone loss. And you can see on this view kind of how the screws go and support or raft the joint surface. So surgical exposure, make an incision over the FCR. You can see this is the FCR right here. You can see your radial artery is just radial, your median nerve is just ulnar. There's a pulmocutaneous branch which sometimes pierces through the FCR sheath. So be careful of it, be cognizant, and look for it. You make your incision through the FCR sheath, move the tendon aside, go through the base of the sheath. Just below there is FPL, which you'll retract ulnarly, and then you'll be looking at your pronator quadratus. When you do that, you need to oftentimes take down your PQ. Sometimes it'll be torn from the initial injury, but I take it down along the radial aspect, protecting my radial artery, of course, and then take it across distally. I tell my residents cut from the ulnar side to the radial side because you don't want to be cutting towards your median nerve, even if it's protected. And then be careful that you don't enter the joint. So you can palpate with a little Adson pickup. You can feel, or this is as a needle, you can feel where the joint surface is, and then come a little bit more proximally right along that white line. But if you leave a little cuff of tissue, you'll be able to repair your PQ over that, which has not been shown in research studies to be clinically relevant. However, I personally think it probably is. And I do try to repair the PQ over the distal aspect of the plate, especially in this ulnar area where the tendons are going to be immediately superficial to it. So surgery, I initially do my reduction, and then I secure the plate with C wires, and then I check with Flora to make sure my reduction is satisfactory. You can completely do your reduction and use multiple K wires to stabilize your fracture first and then put your plate on. Frequently I will kind of make sure that I feel like I'm going to be able to get my reduction nicely, and I'll go ahead and put the plate on with some C wires, and then I reduce my fracture to the plate using it as a template, but that's just as a stylistic choice. Once I put the plate on and I've confirmed that I like where it is, I use a cortical screw to kind of snug or compress the plate to the volar shaft, and then I reduce my distal segment by flexing the wrist down into the plate, place some wires, and then place some screws through the distal aspect of the plate. Once I have a couple of locking screws distally and I've secured at least one screw into the shaft, I'll check my fluoroscopy again, because I don't like to put too many screws in. I think you get a bias, a confirmation bias of what you've already done, and people accept good enough because they don't feel like taking out too many screws. So if you only have to take a few out, it's really not that big a deal. If you have to take 10 out, you're less likely to do it. So check along the way to make sure that you're happy so that you're actually making good choices for your patient. And then you place the rest of your screws. Screw placement's important. There's several ways you can get into trouble with screws. They cannot be prominent dorsally. You can injure the extensor tendons. The most important ones, of course, are the ones that are distal, but of course the shaft ones can also be prominent, so those shouldn't be long either. Distally, I typically only drill unicortically up to the back cortex, and you can kind of use the drill on high speed and bump into the back cortex and just don't go through. And then with the depth gauge, you can measure and you can feel the dorsal cortex. If it's intact, you can just go ahead and measure and put your screws in. If there's comminution where you're measuring and you just are out in soft tissue or you've drilled bicortically, make sure you're subtracting a bit from what you're measuring so that your screws are not too long. You can also check on a skyline view, which is here on the left, where you flex the wrist and shoot through this way. That gives you the dorsal cortex of the distal radius, and you can see that. Another way to do it is called a carpal shoot-through view, where you extend the wrist, similarly shoot through, and you can see the same dorsal cortex here and make sure that your screws are not penetrating out that way. Similarly, the screws should not be intra-articular. Best way to check to make sure they're not in the radicarpal joint is to do a radial inclination view. You can see on the lateral view here, it's hard to tell if the screws are in the joint, but if you bring the laterally oriented wrist 20 degrees up towards the plate of the fluoro, you can see the joint surface quite clearly and be sure that there's not any screws in the joint. The radial styloid screw is frequently a little bit more prominent, and so you'll know that. You can either choose to put it in last or just know that that's the one and make sure that you're only unicortical when you place it. Don't forget your DRUJ as well, because you don't want to be penetrating the sigmoid notch, and you can do that by doing some oblique views. Flexor tendons can also be irritable with volar locking plates. So this was a paper we did with Max Soong. It's called the Soong classification, and it looks at how prominent your volar plate is compared to the watershed line. So what ideally is you want your plate to be proximal to the watershed line and not volar to it. So just like this, if your plate is off the bone, it will be prominent on your flexor tendons as they pass past here. Or if it's too distally placed and extends distal to the watershed line, that can also be problematic. So position your plate proximal to the watershed line, make sure it's flush with the volar cortex. If you need to go more distal because you need to capture a volar rim fracture fragment, use a smaller volar rim plate. So that's tailored for that. They're much less prominent. And if you notice that the plate is prominent or the patient comes in with any flexor tendon crepitus, just take that plate out before they have tendon ruptures. Intraoperatively, if they're shortening, you can do a technique, a couple things. You can release your brachioradialis, sometimes that's helpful. You can peel off the soft tissues that are on the dorsal side of the shaft, which sometimes allows that distal segment to move distally. But you can also do this technique where you place a screw through your plate in the distal aspect of the slotted hole, put a couple screws or wires into the distal segment, translate distally with traction, and then screw it down. So you can see now the screw is at the very proximal edge, and you've probably achieved at least 3 millimeters or more of, depending on how long the slotted hole is in your particular construct, several millimeters of length in that way, and that's quite helpful to do. Sometimes there's translation, so the shaft is a little bit ulnar compared to the distal segment, and one way to do that is to put some screws in distally, put a screw in proximally loose, and then take a baby Holman, or you can take a laminar spreader between the two and push the shaft radially, which then allows for a reduction of that, and that works quite nicely. And then sometimes there's a lot of comminution. This is not a picture showing this, but if there's a lot of comminution or dye punch lesion, you can work through the fracture plane that comes across here by putting a lobster claw and pronating the shaft out of the way. And you free up the dorsal periosteum and pronate this out of the way. And then you're looking up at this roughened fracture surface, and you can realign any dye punched articular segments. Use the carpus as a template, push those up. You can tamp them up. You can put bone graft behind it, and then you can bring the radial shaft back and then plate underneath it, and that works really well. That's also a helpful technique if there's an older fracture, maybe 3 weeks out, where there's a lot of scar dorsally and it's not reducing as well. You can free that up and pronate it out of the way, and you get much better reduction. So articular surface, very important, both at the DRUJ as well as the radicarpal joint. Multiple treatment techniques, important to think through these and know them, so I'm just going to go through briefly. Close reduction and pinning is always an option. It's a cheap option. It's a good option. The only downsides are that you can get pin irritation. You also have to slow them down. You can't move it right away, so they have to either splinter cast them, usually for about 6 weeks. So, but always an option and something to know about. External fixation, I don't do very much at all. I don't think many people do these days, but it can be really helpful for soft tissue injury. I'm not going to go into it, but always know how to do an X-fix if you need to. And work something like this. You can even do this provisionally while you get soft tissue washed out and then come back and do a fixation definitively later with ORIF. Combined volar and dorsal, sometimes a volar plate's simply not enough. You need a little bit more help, either with a radial stylet or something. That can be helpful. And then this is the kind of latest, which is a bridge plate. It's almost like a wrist fusion plate, but not, because it's not intended to fuse anything. It's an internal X-fix, so it stabilizes to the shaft and to either the index or long metacarpal. It spans the zone of injury. It allows for traction. You don't want to get too much traction because you want to make sure your fingers can flex. It does require a second procedure, of course, because you got to wait till the fracture heals and then do a surgery to take this out. So they will have some wrist stiffness. You need to avoid tendon irritation. Make sure that this is flush against the bone. Anyway, good technique to know about. So associated conditions, this is also very important to think through. When you're dealing with a distal radius, always look for a scaphoid fracture, a scapholunate ligament injury, ulnar styloid fractures. Most of the time those do not need any surgery, but when you see it, just make sure that you feel like your DREJ is indeed stable. A distal ulna fracture sometimes is quite unstable and does need surgery, but rare. And then the things that are most pressing, kind of an acute carpal tunnel, like I was mentioning. This is typically, it looks like a compartment syndrome. So they're very painful. It's progressive. It gets worse. They can develop a dense numbness, sometimes even motor weakness. These need a surgical release on an emergent basis. Median nerve contusion is much more common. They'll have some paresthesias that's non-progressive. I usually do release the carpal tunnel if when I go and do the ORIF, but it's not an acute situation. Let's talk about some cases. So this is one that has shortening by a lot. There's a lot of ulnar positive variants. There's comminution of the joint right here. There's some articular step off. And this is going to obviously have a crush of the cancellous bone because it's really quite shortened. So when you bring them back out to length, there's a gap here, which is where this metaphyseal bone void is. But this is exactly what volar locking plate is meant to do. So it wraps or supports under the subchondral bone. You leave this, you do not need to graft that, although you're welcome to if you feel that that's appropriate, and that'll fill in over time, and the plate is more than strong enough to handle that. Sometimes there's a step off in the joint surface. You can see here and here, and potentially some sigmoid notch involvement. This is sometimes where a CT scan can be helpful. The sigmoid notch actually looks okay. The joint surface has a pretty big step off, and that's indicated for ORF, but a volar locking plate works incredibly well for that. You can see right here, if you pronate out of the way, you can get a really nice DREJ view, which shows that there's no hardware in the DREJ, whereas this view is a little difficult to tell. This is a case with a lot of step off. You can see there's a die punch injury down here. There's volar comminution. That's a volar cortex piece that's flipped almost 180. But you can flip it back, you can push all those articular surfaces pieces up and then raft or support them, and that'll do quite nicely. Next is a volar shear. This is a really important injury pattern to recognize because sometimes they don't look too bad, but this fracture actually will proximally migrate, and then as it does, it brings the whole hand volarly and proximally, and that's a problem. So those need surgery, and you can see right here it's worsening. And so these are actually perfect for a volar locking plate. You can put the plate on. They're very unstable, so you can reduce it and it'll tend not to hold just by itself. So you can reduce it, put your plate on, put some wires or maybe a couple screws in the distal segment, and then sequentially start at the proximal end and compress with screws. And as you compress the plate in the shaft to the shaft, it will reduce your fracture really nicely. So that's a nice technique. This is a really comminuted fracture dislocation, very distal. Some median nerve symptoms, obviously need surgery. There's a small volar piece here. And this is an older case, but you can see this used a volar rim plate and a second plate at the radial styloid. And obviously that is going to need to come out later because that's quite prominent for your flexor tendons. This is another one that's a volar rim fracture that you can see is kind of has a Barton variant here. You can see small fracture there, quite comminuted. And this was done elsewhere and came in to see me, having had surgery, because the surgeon realized that they'd missed this fracture fragment and now it has jumped out. You can see on the CT scan, the lunate is not sitting in the lunate fossa. The whole thing is migrated volarly. This needs a revision surgery. Took off the hardware, used this little volar rim plate, which captures that piece really nicely, do this very low profile distal extension, and the patient went on to do fine. Sometimes they're really comminuted. There's more forearm involvement. You may have to do something quite different. Spanning plate was chosen in this case and allowed for some weight bearing. External fixator can also be done. It allows for ligament metaxas. Don't make it too long or you won't be able to move your fingers. And then that can be revised later to an ORF with a volar locking plate. This patient had a scapholunate injury. And in addition to the volar locking plate, the scapholunate was addressed. This patient had an ulnar neck fracture, which you wonder if it's going to be stable or not, but most of the time it is. And after you do the volar locking plate, you can see it pulled the ulna out to perfect length. It's nice and stable and healed without any further intervention for the ulna. This is a little bit different because it has a little bit of a shear oblique fracture. And because of that, I put a couple screws in there. They're not in the DREJ, which is more distal. This has a DREJ disruption, so even after fixing the distal radius, the DREJ was grossly unstable, the elbow was fine, and that was pinned, and the pins are left in for about 6 weeks, making sure that I've reduced and pinned the DREJ. So tendon irritation can happen, either flexor or extensor. They tend to complain of some pain or crepitus. If they do, or you notice it on your exam, get that hardware out. Hand stiffness, I mentioned, can occur even after non-operative treatment. It's very difficult to treat late. Prevention is most important. All patients should be started immediately on digital early range of motion. I give them this sheet. Edema control, elevation, and don't forget the shoulder and elbow. For rehab, most patients with stable fixation, I start immediately with digital range of motion edema control, and then at 2 weeks, I get them moving at their wrist. If I have tenuous fixation, which is less common, but sometimes I might slow them down till about 4 weeks or so, and then get them started moving at that point. It's very rare that I would go past that. So in summary, distal radius fractures are really common. They're very enjoyable to treat. They're really predictable and reliable if done well. There's a variety of treatment options. You're doing yourself and your patient a service by knowing all different methods of treatment to allow the best choice based on that particular patient's needs. And then post-op therapy can be home program or it can be formal hand therapy is really helpful for a good outcome. Thank you very much.